there. My name is Nick Lividas. I'm here with my colleague, Kathy Mills. We both take a leadership responsibility on the clinical delivery in the Northumberland MSK service. A reminder, we're a partnership contract led by the Trust and supported by Connect Health, and we are a self-referral service. So do remember your patients that they can self-refer, and current waiting time is at 5 working days. So very quick access to the MSK team right now. So if we have a look at moving the slide deck on, it would help if it did move on. Let's try. Here we go. We'll pass that. Spinal red flags. So what things are we talking about when we think about red flags for the spine? It's things like cancer, infection, fracture, significant nerve root compression, spinal cord compression, and what we'll come on to, of course, is cord recliner syndrome as well. So these are some of the kind of symptoms we might raise our suspicion of underlying malignancy. So this is from the NICE guidance regarding cancer and the implications for metastatic cord compression, but equally kind of back pain on its own without cord symptoms. And some of the kind of concerning features would be a patient that presents with past or current history of cancer, plus symptoms in the box below. We do have an MSCC coordinator that's available on the phone, and they're based regionally. So we have one, I think, is based at the RVI. So you can pick up switchboard and ask for the MSCC coordinator, and you'll be redirected. But it's things like severe unremitting back pain, progressive pain, mechanical pain, straining, aggravating symptoms, nighttime, local tenderness, or some odd claudicant type symptoms in the leg. Now, some of those symptoms you could argue everyone that presents with back pain would present with, and we're not naturally going to pick up the phone to the MSCC coordinator with anyone with any of these symptoms. So that's where a degree of pragmatism comes in, and accept the guidelines for what they are, but actually make a clinically reasoned decision based on the patient in front of you. So metastatic spinal cord compression. So this is, again, the patient with a history of cancer, which, of course, we know may metastasize to bone some years later quite often, and that is often metastasizing to the spine, of which eventually may encroach on the spinal canal and lead to cord compression. And of course, because it's cord compression, we could be thinking of bladder changes, bowel changes, gait changes, weakness, neurological symptoms progressing to cord recliner, numbness, tingling, with or sometimes without radicular pain. But certainly those features are perhaps easier to pick up than those that are maybe back pain alone. So again, we have the designated MSCC coordinator that can offer really timely, immediate support for those patients that we're not sure of how to best manage. In a number of cases, it might be that this isn't something that needs immediate admission, but it certainly would maybe need an urgent referral through to the MSK service for imaging. A great resource that is available through the local services. Infection, it's really rare. It's quite rare you'll come across these in your career, a spinal infection. Localized progressive pain. They'll have some risk factors, so history of TB, IV drug use. They may already be immunocompromised. So when you've got a patient that presents with a backdrop of that history and unremitting back pain, it just looks a little bit unusual. Keeping infection in your mind as a differential is an important red flag to consider. What about fracture then? So fracture, of course, is a red flag and something we want to pick up early on in primary care. So these may come on from a major traumatic injury, but the ones that can sometimes catch us out are those that come on from a trivial injury. So I slipped and hit my back on the back of a chair, or I jarred my back stepping off the curb or the bottom step slightly. I felt a pain in my back. So that kind of low energy trauma, they'll have localized pain and tenderness to direct pressure on the vertebra. It will typically be unremitting pain, unlike your typical mechanical pain that comes and goes with activity. May present with neurological symptoms if the fracture has had implications on the adjacent nerve roots. And typically these patients might be our older patients, postmenopausal women, which we know their bone density is typically lower, and there may well be a patient that has undiagnosed osteopenia or osteoporosis. Other risk factors related to bone health may be prevalent, such as a history of steroids, smoking, or alcohol. In primary care, these are typically managed with a standard X-ray, and then we can then, if it is confirmed, look at kind of supporting the patient with pain management, and then consider secondary prevention. So if they have kind of suspected first-time, fragility, osteoporotic fracture, then maybe we need to consider how best we can support them in their bone health, either lifestyle or medication, to prevent future fracture. Nerve root compression. So this is one that probably is a red flag, because people may present with a foot drop very early in the presentation of a sciatic episode, which suggests more definitive compression that's affecting the axonal flow of the supply to the motor aspect of the lower limb. So they may say, I've just been walking a bit funny, my foot's not quite moving as well, I'm catching my toes, my foot seems to be flapping as I'm walking. Those kind of things is probably something to add in your subjective screen. A really simple question to say, have you noticed any weakness of your feet, catching of your toes, or slapping of your foot? It is rare, but if it is kind of apparent, and certainly if it's progressive, it would need more urgent escalation to consider whether this is a candidate for surgical decompression, perhaps to prevent lifelong loss of that ability to dorsiflex, which of course would lead to potentially the wearing of an AFO, as you can see in the picture there. But certainly something to be wary of. Podocquitis syndrome, so probably the most feared red flag around the spine, and understandably so for two reasons. It can present with the patient with lifelong, life-changing features of incontinence, inability to get an erection, possibly in many cases wheelchair bound. And then, of course, there's the other aspect of these cases being one of the number one factors leading to litigation within healthcare due to delayed identification. So these are the symptoms there you see in the yellow box. So unilateral or bilateral radicular pain. So if it presents unilaterally, then they develop bilateral symptoms, and that's certainly a red flag. Bladder disturbance, bowel disturbance, and these are new. So not your patients say, oh yeah, my bladder's been a bit funny for years. It's patients that have developed sudden, unexplained new changes to bladder or bowel function. Saddle anesthesia, so that's a question like, when you go to the toilet and wipe, does it feel normal on the skin or different? Sexual disturbance, the question that most people don't ask, but is important. Are you able to get an erection? Can you maintain erection? Can you ejaculate? For females, can you feel penetration? Can you climax? Those questions and any changes subtly related to the onset of, back radicular pain could be related. And new motor weakness as well. So there is a new pathway that was developed towards the end of last year. So that's something for you to familiarize yourself with in terms of when to seek and escalate. And certainly if patients don't present with this, highlight the importance of safety netting, whether that's verbally, ideally with the provision of a leaflet, to try and kind of support your patients to look out for these symptoms. Myelopathy, typically degenerate cervical myelopathy. This essentially means compression to the spinal canal, and the subsequent symptoms that you can see in the box there: poor balance, clumsiness, grip changes, fatigue, dexterity changes, inability to fasten buttons, do zips, etc. And the management of this is really ranging from patients that have quite stable, long-standing symptoms to patients that present very quickly and progress very urgently to what might need to be a surgical decompression. Many patients with this have got low-level grumbling symptoms and are often monitored for a long time with safety netting to look out for the acute changes. Some general spinal red flags to remember, a bit of a mnemonic here. So tuna fish. Is there a history of trauma which links into your kind of osteoporotic fracture? Any weight loss that could indicate more systemic cancer-related symptoms? Neurology, the foot drop, the pins and needles, the numbness. The first onset of back pain under 20, or the first onset ever of back pain over 50 is probably a red flag to consider. Have they got a fever? Is it infective? Is there inflammatory features of, early morning stiffness? Has there been substance misuse in the past which might raise their level of risk to infection? And certainly, is there a history of cancer that presents with this patient that raises my concern here? And your concern will raise on a scale from low to high, and no one single red flag leads us to sending every patient to A&E. Of course, it's it's a complex scenario of many different factors. In a consult, our worry may go up and down, a number of times in a consult to ultimately get us to a decision in terms of how urgent is this. And of course, you've got the option of the JMAP service to, advice and guidance. You've got if it's an orthopedic complaint, it might be a call to the orthopedic registrar team as well. And of course, if it's MSCC, you've got the coordinator on the end of the phone as well. So a few kind of options for support there. And that kind of covers off in terms of management, safety netting, and the importance of documentation, and certainly with your spinal cases, the safety netting of CES. Even with onward referral to JMAPS, that really helps us understand if safety netting has been offered. So, and in most cases, that's already done by you guys. So thank you for that.